Hi, thank you for attending my technician talk today. My name is Tabitha Bice, and I am a PGY1 pharmacy resident at the University of Virginia Health System. And today I will be presenting on the topic of sepsis. I have no disclosures for this presentation. At the conclusion of this presentation, participants should be able to differentiate sepsis and septic shock terminology, identify primary goals for the initial treatment of sepsis, review important medications utilized in the treatment of sepsis, and discuss details of sepsis alerts at the University of Virginia Health System. So sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. In other words, sepsis is a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. And septic shock is defined as circulatory and cellular metabolic dysfunction associated with a higher risk of mortality. Both sepsis and septic shock are considered medical emergencies because anyone with sepsis has a baseline risk of mortality of 10%. And that risk of mortality increases in septic shock. And sepsis has been shown to be the primary cause of death from infection, especially if not recognized and treated promptly, so its recognition mandates urgent attention. So what differentiates sepsis from just infection is this dysregulated host response and the presence of organ dysfunction. So previous treatment guidelines for sepsis defined sepsis as a patient with suspected infection who have two or at least two of the four systemic inflammatory response syndrome or SIRS criteria. And these are a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, a heart rate greater than 90 beats per minute, a respiratory rate greater than 20 beats per minute, breaths per minute, or a white blood cell count greater than 12,000 or less than 4,000 cells per millimeter cubed. And the sepsis alert system at UVA is based upon these SIRS criteria. So this is an old definition that we still use for our scoring system here. However, there is a more recent treatment guideline that assesses these SIRS, that found that the assessment of these SIRS criteria were frequently non-discrete and non-specific to sepsis. So in other words, patients who are critically ill can have two of the four SIRS criteria without having a dysregulated, life-threatening response to infection. Thus, they redefined sepsis with these new treatment guidelines. So the most recent sepsis treatment guidelines defined a new measure to use in evaluating sepsis and septic shock, which is the QSOFA scoring system. So QSOFA stands for Quick Sequential Organ Failure Assessment, which is a rapid bedside scoring tool to evaluate patients with suspected infection for sepsis and organ dysfunction. And the QSOFA scoring system performs superiorly to SIRS criteria in clinical trials assessing sepsis identification and treatment. And the QSOFA clinical criteria are altered mental status, a systolic blood pressure of less than 100 millimeters of mercury, and a respiratory rate greater than 22 breaths per minute. So patients who meet these criteria show evidence of sepsis and organ dysfunction. And a higher QSOFA score is associated with an increased probability of mortality and or prolonged ICU stay if patients are in the ICU. And UVA hasn't made the transition to incorporating this new scoring system into our sepsis response as of now, but I think that will be coming. So septic shock is a subset of sepsis in which underlying circulatory and cellular or metabolic abnormalities are profound enough to substantially increase mortality. And patients with septic shock can be identified as patients with sepsis with persistent hypotension, defined as a systolic blood pressure less than 90 millimeters of mercury, or a mean arterial pressure less than 65. despite adequate fluid resuscitation with IV fluids. And these patients frequently require vasopressors, such as norepinephrine, to maintain their mean arterial pressures greater than 65, and usually these patients have a serum lactate of at least 2. And patients with refractory hypoperfusion can have a lactate value of greater than 4 despite fluid resuscitation, and this shows that the tissues in organs are not being perfused adequately in sepsis. And organ dysfunction can be seen in the kidneys and the liver, particularly in septic shock, and this is also due to a lack of perfusion to these organs. And hospital mortality can be on the upper end of 40% in patients who have septic shock. So as you can see, this is a medical emergency, and thus why we respond very quickly here at UVA for sepsis alerts, and especially patients who present with septic shock. So the goals for initial treatment of sepsis are to begin treatment and fluid resuscitation immediately when these patients present or go into sepsis. And the first goal is to start IV crystalloid fluids, which is normal saline, of at least 30 milliliters per kilogram given within the first 3 hours of when patients present with sepsis. And albumin is only used if patients require a substantial amount of crystalloid or normal saline IV fluid. So albumin is not our go-to for IV fluids. Normal saline has been proven to be the most effective in adequately resuscitating patients who are fluid down in sepsis. And blood culture should be obtained generally right when patients are assessed as well, and definitely before antibiotics are started, because then the yield of blood cultures is much lower, and organisms frequently do not grow if antibiotics are started before blood cultures are drawn. And then IV antibiotics should be started as soon as possible, but particularly within 1 hour of when patients go into sepsis or septic shock. So why is the timing of antibiotics so important in sepsis? There was a very pivotal clinical trial that was performed by Kumar, and it is the reason that antibiotics are considered time-sensitive in sepsis. This trial studied the relationship between a delay in initiation of effective antibiotics from initial onset of hypotension and survival in septic shock. These investigators found that over the first 6 hours after the onset of recurrent or persistent hypotension, which again defines patients as being in septic shock, each hour delay in initiation of effective antibiotics was associated with a mean decrease in survival of 7.6%. So to reiterate, mortality increases by 7.6% for each hour that antibiotics are not started in patients with septic shock. And this graph is from the trial with Kumar that I just spoke about, and it shows the cumulative effective antimicrobial initiation following the onset of septic shock-associated hypotension and associated survival. And the x-axis on this graph represents the time in hours following the first documentation of septic shock-associated hypotension. And then the black bars represent the fraction of patients surviving to hospital discharge for effective therapy initiated within this given time interval. And then the gray bars represent the cumulative fraction of patients having received effective antimicrobials at any given time point. So the far left shows that survival is the highest when antibiotics are initiated as soon as possible. And the more time that elapses from hypotension onset, you see survival decreases with each time interval by the black bars decreasing as you go along the x-axis. So antibiotics are needed to treat the infection, the underlying infection that is causing sepsis in these patients. And broad spectrum therapy should be started with at least one antimicrobial to cover all the likely pathogens causing infection in patients with sepsis and septic shock. So this is very patient-specific depending on their risk factors, what infections they may have had previously, and what they think is causing the infection in this patient right now. But broad spectrum generally means that you would want to cover bacteria that could be causing infection, and then potentially viral and fungal coverage as well. So the most important thing for providers who are assessing patients with sepsis is to figure out the most likely source of infection and the severity of the illness and determine antibiotics based off of those criteria. And antibiotics are usually continued for 7 to 10 days of treatment for most serious infections associated with sepsis and septic shock. However, this can depend on the severity of the illness and the clinical status of the patient as well. And if combination therapy is used, meaning more than one antimicrobial agent, then de-escalation or narrowing to less than 2, so going to at least one antimicrobial that will hopefully cover the likely pathogens, is recommended within the first few days of clinical improvement or evidence of infection resolution. But de-escalation of antimicrobial therapy should always be guided by culture data and pathogen identification, meaning waiting for a bacteria or a fungus to grow on a culture. So the most frequent antimicrobials that are used in sepsis are broad-spectrum antibiotics and sometimes antifungal agents. Gram-negative bacteria are very virulent and will cause mortality the fastest in patients with sepsis. And antibiotics that cover gram-negative bacteria frequently that are used in sepsis are piperacillin tazobactam, which is Zosyn, and cefepime. Those are very broad spectrum antibiotics that cover a large amount of gram-negative bacteria that can frequently cause sepsis. And then gram-positive bacteria can also cause sepsis, and vancomycin covers almost all of the main gram-positive bacteria that we are concerned about in sepsis. An antifungal treatment is sometimes necessary depending on patient-specific factors. So antifungal agents such as fluconazole and micafungin are utilized in sepsis sometimes as well. And generally, this will be in patients with specific risk factors such as being immunocompromised, patients who have been receiving chemotherapy or have a predisposing factor that would make you suspicious that they could have a fungal pathogen causing their infection. And then anaerobic bacteria can be present in infections causing sepsis as well. So metronidazole or Flagyl is frequently used for anaerobic coverage in septic patients as well. And the use of vasopressors to maintain oxygenation of organs and tissues until the infection can be treated is seen in sepsis as well. So vasopressors such as norepinephrine can be used in septic patients. Norepinephrine is deemed in the guidelines as the first choice for a vasopressor in sepsis. And then vasopressin or epinephrine can be added to norepinephrine if patients are requiring a substantial amount of norepinephrine dosage used. And then dopamine can also be an alternative to norepinephrine in some patients who cannot maintain their blood pressure and require vasopressors. And then corticosteroids such as hydrocortisone can be given as well. And hydrocortisone is given at 200 milligrams per day in septic patients only if adequate fluid resuscitation and vasopressor therapy are able to restore a hemodynamic stability in these patients. So here at UVA, we have what we deem as the sepsis emergency response system, where a sepsis alert fires, or a 4 out of 4 SIRS best practice alert, or BPA. And what happens is when a patient meets 4 out of 4 SIRS criteria that we talked about earlier, so a white blood cell count meeting the criteria, a heart rate meeting the criteria, a respiratory rate, or a temperature, if they meet all 4 of those SIRS criteria, then EPIC actually recognizes this and fires a sepsis alert, and a page is sent to all pharmacists and all medical emergency response team nurses, which you may have heard deemed the MET team, which stands for medical emergency response. So pharmacists and MET team nurses get a page saying that a patient has met 4 out of 4 SIRS criteria and thus is deemed to be in sepsis, and they should be evaluated immediately. And then a sprint alert seems similar to a sepsis alert, but a sprint alert stands for a sick patient rapid intervention pharmacist page, which is specific to UVA as well. And this is an alert sent from MET nurses or physicians who need a pharmacist urgently at the patient bedside. And the sprint alert can be utilized for any patient requiring immediate intervention, but usually involves septic patients. And again, the goal is to recognize and treat septic patients as soon as possible. So sometimes they don't meet 4 out of 4 SIRS criteria, but a physician or MET nurse thinks that this patient is probably septic. They can send a sprint alert to then alert a pharmacist to please come to the bedside immediately to help in the evaluation of this patient as well. So a pharmacist responds to all sepsis alerts at UVA, and they are expected to respond to the patient bedside when a MET nurse, with the MET nurse and primary team, when a sepsis alert or a sprint alert is fired. And that's usually determined by which unit the pharmacist is covering, depending on whether it's the weekend or on a weekday. If the pharmacists are already up on the units, then it should be very quick for them to get to the bedside of the patient, but a page is always sent. And the pharmacist should discuss and evaluate the patient with the team to determine if any intervention is necessary. And a SIRS BPA does not always mean that a change in antibiotics is necessary. So sometimes patients continue to have fevers and reach SIRS criteria and seem to be presenting in sepsis again, but they are on the appropriate antibiotics for their infection. So it's just evaluating the patient, making sure that they have all the appropriate therapies that are needed to treat this patient, and then sometimes you don't change any therapy. But when patients are meeting these SIRS criteria, they should always be evaluated by their physicians and nurses and a pharmacist as well. And the pharmacist should also assist the team with implementing any interventions that are discussed. So if there is a decision to start antibiotics or to change antibiotic therapy, then a pharmacist should always make sure that the order is inputted by the physician, and then the pharmacist should verify it as soon as possible, determining whether it's appropriate for this patient and what they discussed with the team. And then the pharmacist should make sure to get antibiotics to the bedside as quickly as possible and within 1 hour, as I discussed with the trial that showed the decreased mortality with starting antibiotics within an hour. And then the new sepsis treatment guidelines also recommend starting antibiotics within an hour as well. And the pharmacist should also assist the team with other medications or fluids that are needed. So like we discussed earlier, making sure the patient has received adequate fluid resuscitation. So if this is their first septic alert, then you would want to make sure that they are receiving the 30 milliliters per kilogram of normal saline within the first 3 hours of their sepsis alert. And then also any medications that are needed, whether they need norepinephrine because they're hypotensive, or hydrocortisone if it is a septic shock patient. So this leads us to our patient case. AB is a 55-year-old male who presents to the UVA emergency department for increasing shortness of breath. His vital signs on initial evaluation are a blood pressure of 134/84, heart rate of 108, a respiratory rate of 30, and a temperature of 39.5 degrees Celsius. His chest x-ray shows concerns for pneumonia. On initial presentation, does AB have sepsis? And if so, which criteria of the SIRS criteria does he meet? So yes, AB does have sepsis. He has a suspected infection, which was shown by his chest x-ray that was concerning for pneumonia. And then in the setting of having a suspected infection, he also has 3 out of 4 of the SIRS criteria. And if you remember from the beginning of my presentation, you have to have at least 2 of the 4 SIRS criteria to be considered to have sepsis in the setting of having a suspected infection as well. So AB had a heart rate greater than 90 beats per minute because his was 108. He had a respiratory rate of greater than 20 breaths per minute, with his being 30 breaths per minute. And then his temperature was greater than 38 degrees Celsius. And now we'll move on to our second patient case. So after the physicians and the pharmacists have assessed AB, they decide to initiate vancomycin and piperacillin tazobactam, or Zosyn, for broad-spectrum antibiotic coverage for potential pathogens that could be causing his pneumonia. The goal to initiate antibiotics within 1 hour of sepsis onset is based on the study by Kumar that we just discussed, that found that survival decreased by how much percent with each hour delay in antibiotic therapy. So the goal to initiate antibiotics within 1 hour of sepsis onset in the Kumar study found that survival decreased by 7.6% with each hour delay of antibiotic therapy. So this is one of my big take-home points from this talk, is that antibiotic therapy in patients presenting with sepsis or that are in septic shock need to have antibiotics that cover all the likely pathogens of their infection started within 1 hour, which is why there is a lot of time sensitivity based around sepsis alerts and sprint alerts, and why pharmacists and pharmacy technicians are so essential to making sure that patients receive antibiotics at the appropriate time and within this goal of 1 hour, so that we can decrease their mortality by almost 8% within that first hour. And if you have any questions, feel free to email me. Again, my name is Tabitha Bice, and thank you for listening to this talk.
Can I ask one question?
Yes.
Also, so as far as like the 4 defining features, is there any type of like prolonged time frame that those have to be recognized? Because I would think that like the heart rate and then the heavy breathing, somebody who's just maybe stressing out over an illness or something, or may show those, signs for a short period of time. Is there anything, I guess, delineating between just maybe stress or shock and actually septic shock?
And that's a really great question, because I think that's basically why they redefined the sepsis criteria, because the SIRS criteria it doesn't have to be someone who is in sepsis or septic shock. So you can have all of these, like you said, all of these clinical signs at one time. If you're stressed, if something is going on, that may not indicate sepsis, which is why they went to the QSOFA score that we haven't implemented here at UVA yet. But the QSOFA score is a little more indicative of just sepsis, so the altered mental status with the hypotension and the increased respiratory rate is a little more indicative of sepsis, because the SIRS criteria can be non-specific for just sepsis, because sick patients can present that way. Well, that's a good question.
Okay.
Yep.
Thanks.
Thank you.